Hello, and welcome to the latest CSF podcast on axial spondyloarthritis. We'll be bringing you new episodes on a monthly basis alongside our RA and PSA podcasts, and we'll also be supplying you with monthly slide decks to help you keep up to date with the latest research and publications in the field of axial SpA. First of all, allow me to introduce myself. I'm Sofia Ramiro. I'm a consultant rheumatologist and senior researcher at Zuyderland Medical Center and at Leiden University Medical Center in the Netherlands. With me now today, we have Professor Atul Deodhar, Professor of Medicine and Medical Director of Rheumatology Clinics in the Division of Arthritis and Rheumatic Diseases at Oregon Health Science University in Portland, USA, as well as Professor Hideto Kameda, Professor on Internal Medicine at Toho University. And of course, if you want to find out more about us and the papers we will be discussing today, please head over to the CSF website, www.cytokinesignaling.com. So Atul, over to you, and I think we can get started. Tell us what we will be discussing today, please.
Yeah, thank you, Sofia. Our first paper describes the safety and efficacy of Ixekizumab treatment in patients with radiographic axial SpA and non-radiographic axial SpA for up to 156 weeks, and I will describe that. And our second study today goes on to assess the safety and efficacy of Tildrakizumab. This is the P19 IL-23 inhibitor in patients with active ankylosing spondylitis. So the first paper is titled Long-Term Safety and Efficacy of Ixekizumab in Patients with Axial Spondyloarthritis, 3 years data from the COAST program. So the background is like this. For patients who are receiving long-term treatment, determining the safety profile of a biologic from multiple studies and long-term extension studies is of utmost importance. This study reported the safety and efficacy of patients with radiographic and non-radiographic axial spondyloarthritis for up to 156 weeks in COAST-Y. And this COAST program is somewhat complicated, so let me explain. COAST-Y is a long-term extension. It's a 2-year extension of 3 originating studies, and these 3 originating studies were all 52 weeks long. Those are COAST-V, COAST-W, and COAST-X. COAST-V and COAST-W were the studies in radiographic axial SpA. COAST-V was biologic DMARD naive. COAST-W was biologic, actually TNF inhibitor experienced, both 52 weeks. And COAST-X was the non-radiographic axial SpA. These are all biologic DMARD naive patients. All these 3 studies are 52 weeks, and after they were over, then the patients rolled into COAST-Y, which was further 2-year long-term extension. So the 3-year extension is 1 year in the originating study and 2 years more. So in COAST-Y, patients continued with the dose received at the end of the originating study. And remember, there were 2 dosages, 80 milligram of Ixekizumab, either every 4 weeks, which is the dose which is approved for the treatment, or even every 2 weeks. Starting at week 116, which is week 64 of COAST-Y, patients receiving Ixekizumab every 4 weeks could be escalated to every 2 weeks if required. And the safety of patients who received at least 1 dose of Ixekizumab and also efficacy was assessed in this paper that I'm describing. So the safety and efficacy of Ixekizumab in axial SpA were analyzed in a subset of patients who received more than 1 dose of Ixekizumab during the 3-year COAST study. So the results are as follows. So all patient groups receiving Ixekizumab every 4 weeks were assessed through 3 years. They saw sustained improvement in the ASDAS score and ASDAS CII, or ASDAS clinically important improvement, as well as other efficacy endpoints. 932 patients received more than 1 dose of Ixekizumab between week 0 of the originating study and week 156. 82.9%, so 83% actually entered COAST-Y. These are 773 out of 932 patients. So 83% patients entered COAST-Y after completing their 1-year originating study. And 67.7, so 68% completed the complete 3-year COAST program. So that gives you an idea of how many patients stayed in the study. The conclusions are the 3-year safety profile, which is the most important one, of ICSI in the COAST program was consistent with the previously established long-term safety profile. And of course, we are concerned about inflammatory bowel disease, and I can tell you that it was 0.8 per 100 patient years. And the Candida is we are always concerned about, and this was all sort of, it was oral Candida, esophageal, skin Candida, vulvovaginal Candida. It was total 0.8 also per 100 patient years. And that was the more interesting part of it. Otherwise, there were 3 deaths which were unrelated in this whole program. There were not many. The uveitis rate was 2.8 per 100 patient years. So ixekizumab once every 4 weeks provided a sustained improvement of the disease activity in the patients who received it for 3 years. And the safety profile, as I said, was quite consistent with what we have known from the other studies done on ixekizumab. So I will open it for discussion if you have any questions for me or anything you want to ask.
Thank you very much, Atul. I think these are very important data because when we have long-term studies or when we have a trial, we are interested in long-term follow-up, particularly for safety. So I think you already emphasized that safety was reassuring in terms that actually no new safety signals were found in this long-term extension, correct?
Yeah, interestingly, so as I said, there was one group which received every Q4 weeks, which is how we use ixekizumab. There was one group which received Q2 weeks. And we also looked at whether there was a difference because, of course, Q2 weeks patient received double the dose of ixekizumab for 3 years. And the numbers that I quoted for infection, mostly Candida, of course, and other infections as well, they were not increased in Q2 week compared to Q4 week, which is point number 1. Point number 2 I quickly want to make is injection site reactions. Now, this is an old preparation of ixekizumab. They have changed the components of the drug, and now the injection site reactions are less, but this is the old one. Injection site reactions did double, of course, in the Q2 week. But beyond that, Q2 week and Q4 weeks, there was not much difference.
And in terms of the duration of the trial, especially, for example, the candidiasis, were they occurring more in the early phases of treatment, of later phases? Do you have that information?
Yes, a great question. And we did look at first year, second year, third year, and there was no difference. It was flat. So it's neither going up nor going down either. It's quite stable, sort of. It's not, So great question. We did look at year-to-year changes.
Yeah. And after a period of 3 years, I think malignancies also start being an important topic because we know less about IL-17 inhibition on long-term malignancies. Do you have information on that?
So, there were hardly any malignancies. There were 1 or 2, and I can't offhand remember those. Same thing with MACE, same thing with depression. The 3 deaths, there was 1 suicide among the 3 deaths. 1 was homicide, sadly, and 1 was sepsis. But overall, there was no increase in malignancies or depression or ischemic heart disease.
Okay, I think these data are reassuring. Thank you very much. I think now over to you, Hideto.
Okay, so when we compare the 3 study groups, we always see that the best response for bio-naive radiographic r-axSpA as compared with bio-experienced or bio-naive non-radiographic. So when we compare non-radiographic versus radiographic r-axSpA, why radiographic patients shows a better response than non-radiographic? For rheumatoid arthritis, usually earlier the better, they say. But for r-axSpA, it's not. So some population difference or some homogeneous or heterogeneous populations?
Yeah, I mean, it's a great question, Hideto. I believe there are a couple of ways I can answer this question. Number 1 is that the non-radiographic, we are finding there is a creep up of placebo responses. For some reason, the newer studies, the placebo responses are going up and up. And patients are expecting more responses from the drug. And that's why the delta between the placebo and the active drug is becoming less. And we are seeing this across in rheumatology. We are seeing this in rheumatoid arthritis, psoriatic arthritis, axSpA, non-radiographic axSpA, that patients expect more from biologics, and there is a creep up of the placebo response, and the delta becomes smaller. The second thing is the non-radiographic axial SPA patients. We don't really specifically look for other causes of pain, i.e. central sensitization, fibromyalgia, etc. And I'm not saying that problem is less in radiographic axial SPA, but in non-radiographic axial SPA, there may be some few patients here and there which may have predominant central sensitization, fibromyalgia, etc. And that, of course, the outcome measures that we have, ASAS-20 and ASDAS, apart from CRP, everything else is patient-driven. And that kind of makes it, sometimes the responses are less because the patients with central sensitization are not responding.
Okay, thank you, Atul.
Another comment on that, Atul, what do you think about the fact that we are wanting to diagnose our diseases in an earlier phase? So in a phase of non-radiographic phase, which of course poses some more challenges. And I think it's no shame to say that even among experts, it's a diagnosis that is not always straightforward. So can we also consider that as a potential explanation or contributing to this?
Yeah, absolutely. And Sofia, the treatment recommendations that you authored for ASAS and EULAR, it does say this is one important thing there, a new one, is that if the patient is not responding, go back and look at yourself and see that whether the diagnosis is correct. Rheumatology is a branch of uncertainty. And I always tell this to my fellows. This is my famous sentence. All my fellows will tell you. It's a branch of uncertainty. And even though we make the diagnosis, there is this kind of gray area, yay or nay, or maybe, et cetera, et cetera. And so no shame in going back and re-looking at your own diagnosis, because you think, I'm pretty confident this is, but I'm not 100% confident. And then go back and, we should change the diagnosis. It becomes a little bit difficult from the patient's point of view to accept that the doctor doesn't know what he or she is talking about. But that's the reality of our branch of medicine.
Totally agree with you. That's exactly why I made this comment.
Yes, absolutely agree. Okay, so onto the second paper entitled A Randomized Double-Blind Placebo-Controlled Phase 2A Study of Tildrakizumab, Efficacy and Safety in Patients with Active Ankylosing Spondylitis. The study background: the interleukin-23 and 17 pathway is implicated in ankylosing spondylitis pathogenesis, and interleukin-17 and IL-23 inhibitors have been assessed as treatments for ankylosing spondylitis. IL-17 inhibitors such as secukinumab and ixekizumab are approved for treatment of ankylosing spondylitis, but to date, IL-23 inhibitors, risankizumab and ustekinumab, have failed to show clinical efficacy in patients with ankylosing spondylitis. So, this study evaluated the efficacy and safety of tildrakizumab, an anti-IL-23p19 monoclonal antibody, which has been approved to treat moderate to severe plaque psoriasis in patients with ankylosing spondylitis. So for the methods, the study was a 3-part, 72-week, multinational randomized double-blind placebo-controlled phase 2A study. The study comprised, first, a double-blind placebo-controlled period from weeks 0 to 24, in which patients with active AES aged 18 or over were randomized 1-to-1 to tildrakizumab 200 mg or placebo every 4 weeks after a screening period from week -4 to 0. The second, a 28-week follow-up treatment period between week 24 and 52, where all patients received tildrakizumab 200 mg every 4 weeks. And the third, a 20-week washout period between week 52 and 72. So we're moving to the results. tildrakizumab treatment was generally well tolerated with no unexpected safety findings. Instance of treatment-emergent adverse events was generally similar between treatment arms. The majority of treatment-emergent adverse events were mild or moderate in severity, and no deaths were reported during the study. At week 24, the ANSWER-20 response rate was 74% in patients receiving tildrakizumab 200 mg versus 80.4%, very high, in placebo-treated patients. So, as you see, the primary endpoint was not met, and the study was terminated after the week 24 interim analysis due to lack of efficacy. In addition, the changes from baseline in spine and sacroiliac joint MRI scores did not differ significantly between treatment arms at any of the time points analyzed. So in conclusion, the R23, R17 signaling pathway has been implicated in AS pathogenesis. Although no safety issues were identified, tildrakizumab treatment did not reduce AS disease activity or improve MRI findings in the spine and sacroiliac joints. The failure of tildrakizumab to show clinical efficacy in AS confirms results of previous studies of ustekinumab and risankizumab. In light of these findings, the role of R23 in the pathophysiology of this disease should be revisited to explore the possibility that AS is regulated by R23-dependent and R23-independent pathways in specific tissues or at different times. So now it's convincing that R23 P19 inhibitor is not well work for at least radiographic r-axSpA patients. So what's your comment from Atul or Sofia?
Thank you very much, Hideto. Very clear indeed. I think it's more and more convincing that it doesn't work. That was also the previous evidence that we already had, as you mentioned. Although I have to say that with this trial, I can't help being or questioning a placebo response of 80% and a placebo response that is higher of the one from the active treatment. I think that can only raise questions. Actually, I'm happy that Atul mentioned in the previous discussion the fact that we are seeing increasing placebo responses. That is true, but this is beyond anything seen before, and to a point that I think it can only raise questions. Do you have any explanation for this?
Okay. So we are very lucky because in this study, we have MRI score, both spine and MRI. So we are convincing that R23 P19 inhibitor tildrakizumab is not working for these patients.
Yes.
So such kind of objective findings or objective methods is very, very important for this kind of study.
Totally agree with you. I think that was very good in this study that there are no doubts that it doesn't work, but still I consider placebo responses of 80% very worrisome. If I was a drug regulation authority, I would be worried about this. So and this is not representative. So that's the point I want to make. Although Atul was telling us that placebo responses are increasing, I think you don't recognize this type of placebo responses either, right, Atul?
Is absolutely stunning. And so, Hideto, do you know or did you read which countries were mostly represented?
Yes.
Where did the patients come from? And
I believe they're United States.
Mostly, really?
I think so.
There were 4 countries that I remember where the patients were recruited from. It was Poland, Spain, Hungary, and United States.
Yeah,
it's only 4 countries. It's only those 4 countries.
Wow. Yep. Yeah. So the reason I ask is, I mean, so I have thought about this as to why is this, and I mentioned this earlier, there is this placebo response creep, and I completely agree with Sofia, and that 80%. I mean, this is eye-popping. This is unbelievable. There is the only other study I can think of is an osteoarthritis study we were part of. Glucosamine versus chondroitin versus glucosamine chondroitin combination versus celecoxib versus placebo. So there were 5 groups. This was a large multi-center study done in the US in the Veterans Administration to once and for all answer whether glucosamine chondroitin really work. And people were told that you're participating in glucosamine chondroitin studies, and patients were excited. This study filled up pretty quickly because there is this general belief that glucosamine chondroitin works. And in that study, the sort of placebo response rates were 65%, 70%, or something like that. It was eye-popping as to how much people believed in this. And the reason I bring that study up is because people nowadays believe that these drugs, biologics, are amazing, and they see the advertisements and they expect I'm participating in the study. And so there is that expectation bias, which has led to high placebo response rate, which in the past, there was no such expectation in patients in ankylosing spondylitis, original studies on etanercept and infliximab, etc. So I think that is what I'm thinking. I just had a question, Hideto. That last sentence that you said, I mean, this IL-23 doesn't work, and it's very clear. But then there's some IL-23 dependent and IL-23 independent pathways in specific tissue, different times. I just want you to expand a little bit on that. What do you think? Why is that IL-23 doesn't work?
Okay. So I don't know. So because it's AS patients, so radiographic, so later stage. So how about the very, very early stage of actual SPA or some actual PSA? So I think that for enthesitis, R23 works, but it depends on the stage of the disease. For rheumatoid arthritis, someone says that R17 may be involved in the very, very early stage, but not the obviously rheumatoid arthritis stage. So some difference with the phase, or as well as the site tissue specificity, is very important for the pathogenesis of actual SPA, I think.
Do you think IL-23 is in the early stage is important in the pathogenesis? IL-23, if it is important in the early stage, but not in the late stage, then
yes, that's
if you give IL-23, if you give IL-23 inhibition in an established disease, then it's not really going to work because it's not really. So that's the different in times. And specific tissues, that's very important and interesting as well, because IL-23 inhibition clearly works in the enthesitis of peripheral skeleton. But the enthesitis of the axial skeleton, clearly IL-23 is not working. So that's the difference in the tissues. So difference in the tissues and difference in the times.
Yes,
that's a very interesting way of explaining this.
And I think also the hypothesis that there is still the possibility that there's still IL-17 in circulation that is not inhibited by the IL-23, although it's the same axis, and therefore the disease remains active and is not controlled with IL-23 inhibition. That's also a possibility.
Yep. Can I ask a last question, or just one question? Another one is do you, both of you, either of you, believe that IL-23 inhibition would work in axial PSA?
That's a very nice question, because I agree with some Brown and also Landry's paper said, and I believe that the patient with psoriasis see the improvement of psoriatic skin disease and sometimes peripheral joint disease, then it's very difficult to feel no improvement in backbone or something. So it's kind of a coexistence bias.
And I think before we go into that, I think we clearly have to have an agreement on what is actual PSA, and is it really a separate entity, or is it close to actual SPA?
Yes.
And therefore, so and as you know, there are developments in the field, and there's the AXIS study ongoing that I think will give us clarification of a consensus definition of what is actual PSA. and then it's suitable to investigate it.
Yep. Thank you.
Yes.
Thank you.
Okay.
Exciting.
Thank you very much for this interesting discussions. Now, thank you all for joining us for this r-axSpA podcast brought to you by the CSF. We really hope you find it useful. If you did, don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from, so that you don't miss any future episodes. If you want to read more about what we've discussed today, head over to cytokinesignaling.com, where you'll find detailed summary slides of each of the papers. See you next time.